Hello and welcome everyone. I am Autumn Lintz, the Education Manager here at the Foundation. Thank you for joining our Answers from the Experts Q&A. We are very excited to have you here. Before I introduce our wonderful panelists, I'd like to go over some housekeeping. Q&A. Please add your questions to the Q&A tool in Zoom. We will be recording this and the video will be available on the Foundation's YouTube channel in a few days. Next, we would like to thank our individual donors and our funding partners for making programs like this possible. We cannot do it without you. This is how we exist, and this is how we are able to produce patient educational forums, webinars, publications, and other education materials, so thank you for your donation. Upon the conclusion of the webinar, there will be a survey that pops up on your screen as you exit. We would appreciate you taking the time to complete the survey. Now, I would like to share some information on our speakers today. First, we have Dr. Barbara Pro, who specializes in hematology and oncology. She is the clinical director of the lymphoma program at the Herbert Living Comprehensive Cancer Center at New York Presbyterian Columbia. She leads a multidisciplinary team of lymphoma experts dedicated to translating discoveries in the lab into new and better treatments for patients. Her research and clinical practice focuses on T-cell lymphoma, a rare form of non-Hodgkin lymphoma. She is widely recognized for expertise in drug development for Hodgkin and non-Hodgkin lymphomas. She leads the multi-center clinical trials evaluating new targeted therapies for patients with aggressive lymphoma subtypes, which have led to FDA approvals of novel agents. We also have Dr. Cecilia LaRocca. She is a dermatologist, oncologist at Brigham and Women's Hospital with appointments in the Center for Cutaneous Oncology and Melanoma at the Dana-Farber Cancer Institute. She directly cares for patients with cutaneous and peripheral T-cell lymphoma in a multidisciplinary clinic alongside medical and radiation oncologists at one of the largest specialized centers in the country with a robust program in basic and translational science and clinical trials. Her clinical and translational research efforts focus on improving care of cutaneous lymphoma patients. Specifically, she provides clinical support as an investigator in therapeutic clinical trials conducted at DFCI and helps coordinate efforts to genetically profile CTCL lymphoma patient samples. Let's go ahead and welcome Dr. LaRocca and Dr. Pro. Thank you for joining us.
Hi, Autumn. Thank you for having us.
Thank you so much for the kind introduction and giving us the opportunity to be here with you today.
Wonderful. So let's go ahead and start with our first question. Although people are different, what is generally the time frame for progression to advanced stages when starting at stage 1A?
Thanks, Autumn. I can take that question. I guess the first implication of that question is that the individual who asked it is assuming that someone who has stage 1A will go on to develop progressive disease. But in fact, that is not the case for all patients. Many patients with stage 1A disease, about 85% of them, do not go on to experience any disease progression. Of that small percentage of patients that do go on to develop disease progression, no timeline as to when that is expected to occur. And it's certainly, unfortunately, no great biomarkers to figure out who is at risk of developing disease progression. And even though disease progression sounds quite scary, oftentimes that just means bumping up to a slightly higher grade of disease. And that can be as simple as getting more than 10% of your body surface area affected if you have stage 1A disease. Doesn't automatically mean that you progress to the most advanced stages.
Thank you so much. That was a really good answer. We want to move on to our next question. Do the treatments for mycosis fungoides have a negative impact on the T cells in the blood? Dr. Pro, would you like to tackle this one?
Yeah, sure. So I'm not sure I understand, what the question is, but I will try to try to answer this question. So the T cells in the blood, are very important, as you know, and in any T cell malignancy, we do think that there is a dysfunction of those T cells. So for patients with peripheral blood involvement, it's really important that the treatments actually affect the T cell in the blood. For patients who do not have peripheral blood involvement, typically the treatments that we use are not affecting the T cells. In fact, we don't typically see infections that are associated with T cell depletion or T cell malfunction. However, it all depends whether or not those T cells in the blood are also affected by the disease.
And I would have
Okay,
to
thank
agree
you.
with Dr. Pro. From the dermatology perspective, if we're just talking about patients with mycosis fungoides who don't have disease in the blood, none of the topicals, so the creams or gels that we use, will affect their blood compartment or their immune system internally. And of the oral medications that we give, like bixaritine or methotrexate, only methotrexate has a very small report of increased risk of infections, but it is something that is far minimal compared to the great benefit that it patients.
Okay, thank you both for tackling that question. For patients with mycosis fungoides, are there negative impacts on fingernails? I'm having trouble with brittle and misshaped fingernails. I'm not sure who can handle that question.
I can talk about that. Nails are well within dermatology. So it's a tough question because there are actually a lot of different reasons why someone's nails might be affected. And I guess the first question is, what does the skin around the nails look like? Could it possibly be that the nails are affected because there is lymphoma surrounding the nails? So I think that's the first question that I would address. The second is, try to think about what treatments you're doing. And if those treatments involve using a number of topicals that then you're washing your hands frequently with, just the wear and tear of washing your hands frequently can affect the nails, can cause brittleness. With respect to specific treatments used for CTCL, a number of them can have very mild effects on the skin. Topical steroids might increase the risk of fungal infections. And so could it be a disease unrelated to the topicals, but really a secondary, nail fungus? Or could it be a little bit of irritant and drying and stimulation from the gels that you're using for treating the disease that is just causing, again, wear and tear on the nails? So a lot of different reasons for that to be the case, but I wouldn't be surprised if there's some degree of nail brittleness that you're seeing.
And it's a good point on washing the hands, but the more water you're getting on it, both the skin and the nails get affected. So this next question is one that we do see a lot, and one of the things that I like that the question was asked typically. So I just want to give our little caveat that Dr. LaRocca and Dr. Pro are answering your questions, and you are not their patients. So they're going to give you some generalities or what they have seen, but none of the questions that are being answered here today, please do not consider this a second opinion. You just want to share some knowledge, but this is not a second opinion. So, what is the biggest impact cutaneous lymphoma has on a patient's life typically? And I think this is something that both of you could have some insight on.
Yeah, I have to say this is a question that we are really interested as a physician to try to understand more. But the answer really comes directly from patients, and they're our greatest teachers here in terms of helping us understand how cutaneous lymphoma affects any given individual. And there's no right or wrong way in which the disease impacts someone's life, and it can really vary from early stage to advanced stage. So again, this is a very difficult one to answer, but I can certainly say that some of the emotions and stresses that patients have shared with us along the way really range from a lot of sort of fear and anxiety about the unknown, kind of that question regarding risk of disease progression, the kind of fear and concern that comes with living with a cancer, the sense of otherness that no other individual carries such a rare condition like yourself, and a lot of sadness sometimes around this diagnosis that sometimes can be. Aside from that, there could just be plain annoyance and anger because there's so much maintenance involved in treating the skin, especially if you're doing combination therapies that require a combination of medications that Dr. Pro will give plus topical steroids. So there's a lot of ways in which it can really affect a person's well-being. And that's not even beginning to talk about the symptoms that someone might feel from their cutaneous lymphoma, from itch, burning, stinging, irritation, just the flaking that occurs. And again, those symptoms vary across the spectrum of disease. So it's really hard to say how any one person should feel with lymphoma. We certainly have many patients who are able to go on and lead very happy and successful lives and keep their disease well controlled. But we know that's not the case for everyone. So it's really difficult to say, but we want to learn more from you. And the more you share with the doctors, the better able, hopefully, they are to help one another.
Thank you so much on that. Dr. Pro, is there anything you'd like to add?
No, and I think it depends also on, the stage of the disease and the type of treatment that patients are receiving, because, side effects and also, some of the emotional burden could be different depending on whether or not the patient have limited stage or just receiving topical treatment versus patients who have more advanced stage and are receiving systemic treatment intravenously. So I think it also depends on where the patient is.
Okay, thank you. All right, our next question. I would like to know how CAR T trials are looking for CTCL, especially mycosis fungoides. Dr. Pro, is that any of the ones that you've been working on?
Absolutely. So I think CAR T cell therapy is really changing completely the way we are treating lymphoma. And you probably are aware that there are a number of these treatments that are currently approved for B-cell lymphoma. But unfortunately, the progress has not been very, very rapid in developing these kind of therapies in T-cell lymphoma. And that's because, we are actually using T-cell to attack T-cells. So not easy to really come up with a product that will not kill the patient's own T cells. But having said that, I think, there are a number of clinical trials that are exploring this type of therapy in T-cell lymphoma in general, including mycosis fungoides. And we know that this approach is feasible. We just don't have enough data about how effective it is. But there are a number of investigators that are working very, very hard on these clinical trials.
The clinical trials are very important, and the more that they're out there and the more people that participate, the more treatments that we can find. So thank you. Right. Is it possible to have more than one variant of cutaneous lymphoma at the same time, and how common is it? Oof, that's a good one.
I guess I can. It's possible to have more than one variant of lymphoma at any given time.
I'm sorry to interrupt. We lost you for a second. Can you start the answer again? Because it was right when you said if or is or isn't.
Yes, I think it is possible that one individual may have more than one variant of lymphoma or carry multiple diagnoses under the umbrella of cutaneous T-cell lymphoma. With that said, it is highly, highly uncommon and not something that I see typically. I think the most common example might be someone who has lymphomatoid papulosis and primary cutaneous anaplastic large cell lymphoma, or someone who has mycosis fungoides and lymphomatoid papulosis. With that said, there are some patients who look like a classic mycosis fungoides patient who presents first with fixed, patches or plaques, so fixed spots on the skin, and over time develop disease in the blood and more widespread involvement in the skin. So they might actually then look like they have Sézary syndrome. So there is a little bit of overlap between these diseases. It's not always easy to separate what diagnosis a patient carries at any given time, but not common.
Okay, thank you so much. It's scary, especially when you're first diagnosed and people go on the internet and start looking at things, and sometimes they start hearing all kinds of things about you can have this and that. So it's good to have accurate information. In patients with mycosis fungoides, is there a chance it will go away later in life? If so, how much?
Yeah, I think I can talk about the early stage patients. In terms of early stage patients, we have had a few patients where after treatment, in particular forms of phototherapy like PUVA, immunotherapy like imiquimod, achieved sustained remissions. Although we're really hesitant to use the word cure because it's certainly possible that after a certain amount of years, it may pop up again. And while that seems scary, the idea that it may come back, even though it's gone away for so many years, that doesn't necessarily mean that that patient is going to go on to have a worse outcome over time. But have I seen patients where it's been at least 5 years and really nothing has come back? In my short time caring for patients, will that be the same in the next 10, 20 years? I'm not so sure. But I have seen pretty sustained remissions in some early stage patients.
Dr. Pro, would you like to address the question for advanced
Yeah,
stage?
no, yes, I do think that whatever Dr. LaRocca just said applies also to advanced stage. I think, some patients have remarkable responses to systemic therapy. And so it's not uncommon that after they complete systemic aggressive therapy, they could actually go back to using some of the topical treatments. So and I think also it's important to remember that every day we are really discovering something new in these diseases. And I think our goal, and that's why, as you said, Autumn, clinical trials are so important. Our goal is really to find more effective treatments so that this, is not a chronic disease anymore, but is a disease where we have long period of remission and we can have even, a cure. So this is what we are working on. There are many, many ongoing clinical trials that are looking at completely novel ways to treat this disease. And if, again, with these promising results, we do hope that in the near future, patients can achieve more durable remissions.
It's good to hear that things are coming along, which kind of segues perfectly into our next question. With advancements in medicine, do you think there will ever be a cure for cutaneous T-cell lymphoma? Whoever wants to go at that one. We always get that question.
Yeah, and I think it's a great question. And I think we don't have a crystal ball, but that certainly is the intention, I think, of researchers and oncologists and dermatologists who care for this, is to keep fighting and searching for drugs that could potentially amount to a cure.
Wonderful, thank you. I heard Dr. Pro, you had mentioned PUVA a little bit ago, but this question is, what's your opinion on PUVA light therapy for treating stage 1A MF?
Yeah, I think that was
more of a Dr. Yoka.
Yeah, I'll talk about that. That's something we consider using very often. So PUVA is a type of phototherapy that involves kind of two steps. One is taking a medication that sensitizes you to UVA radiation. PUVA is probably one of the most longstanding treatments that have been available for CTCL, and so we know a lot about it. We know that it's quite effective. However, we've also learned that it does significantly increase your risk for skin cancers. And so in general, if we are considering light treatment, we often start with something like narrow band UVB, which is just as good for mycosis fungoides, but does not carry that risk of increased skin cancers down the line. With that said, for patients who might not have had improvement with narrowband UVB, PUVA is sort of the next step that we go to. to stick with the phototherapy. So it certainly has a role to play for treating mycosis fungoides, especially for someone who has many spots in many different locations, especially if they haven't improved on other forms of treatment. As a first-line treatment, I can imagine there could be circumstances in which one would consider PUVA first, but because of the risk of skin cancer, I tend to personally use it a little bit later on after patients have tried some other option.
Okay, thank you so much. Our next one, we've heard this a couple of times in some of our Q&As, is there been any information that's been discovered regarding excessive perspiration from having mycosis fungoides? Have either of you seen that in your patients?
It's a great question. Actually, I don't know that I've talked about it in depth with any of my patients, but what we do see in dermatology is that certain inflammatory skin conditions often cause the opposite sweat gland function, and there might be reduced sweating, which might then lead to overheating. And so the question is it truly excessive perspiration that someone is experiencing, or is it increased flushing and sort of heat because of the absence of perspiration? I have not seen any specific research or had any additional conversations regarding what role perspiration might be playing in this treatment. So I'm certainly curious to learn more from you guys in terms of what you've observed and experienced.
All right, thank you. We're talking about hematological analysis. So what hematological analysis are necessary to stage the disease in the case of LYP? It's a little bit more of a lab question.
Sure, I can answer that one. So patients with lymphomatoid papulosis, well, I guess let me take a step back. I think the first step is to really establish whether the patient has lymphomatoid papulosis versus some other form. And in that initial workup, some blood tests may be done. But once you feel confident that a person has lymphomatoid papulosis, at that point, some of the blood work that gets done, and it's blood work recommended by the National Comprehensive Cancer Network, is just a basic, complete blood count, a test called LDH, just to get a sense of active inflammation. And these tests are really seen as sort of a screening test to see if there's any other potential cancer-like processes going on within any given individual. But we do not think that LYP affects the blood. So there's no kind of blood work specific to LYP staging that gets done, but rather blood work that gets done to evaluate whether or not this person is at risk for having another form of cancer.
Okay, thank you so much on that one. So this one's a bit of a two-parter. So Mike, if we can leave the question up there a little bit to make sure. And we seem to be getting a lot of questions that are directed to Dr. LaRocca. So on this one is, are there ways to ease itching besides the standard topicals, emollients, such as with food or supplements? Alternate ways to improve skin barrier and or immune system that helps?
I wish I had a great way to answer this question. This is probably one of the toughest things that we do as dermatologists. I think I would take a step back and say the most effective tool we have to treat itch is to treat the therapies that Dr. Pro might provide, or therapies that a dermatologist might prescribe. In terms of soothing itch, aside from creams and emollients, there are oral pills that can be prescribed that might help lessen the itch. But if someone is looking for a more kind of naturopathic approach to treating itch through food or supplements, there are no particular foods or supplements that have been studied directly in the context of lymphoma, and certainly the research isn't in other dermatologic conditions to really give any advice with great confidence. I will say that there doesn't seem to be anything that we know of that can make it worse. Aside from that, some basic things that are beyond sort of topicals and emollients that can be quite helpful. And I know a lot of people don't like the sound of this, but it's taking dilute bleach baths. So it's basically turning your bathtub into a swimming pool. Very safe. Even young babies who have eczema do the same routine. Does is it's likely anti-inflammatory and quite soothing for the skin. So we know that this can really help itch in some folks who have pretty widespread disease. Or good old oatmeal bath, and in many CVS's or other pharmacies, you can find these little oatmeal packets that you use to dissolve in the tub to kind of get a soothing soak that's beyond the topicals and the creams.
I am a big fan of the oatmeal packets. I used to get poison ivy a lot, and that is just so soothing for the itch to sit in the tub. Plus, I like taking the bath, so it just adds to it. Okay, Mike, next question. And Dr. Pro, maybe you can address this one with some of the trials that you've worked on. So with regards to clinical trials, what are generally the timeframes from initial trials to approval for use?
That is a great question. And I will say, unfortunately, it depends. Remember, T-cell lymphoma in general are so rare, and so is mycosis fungoides. So in order to really complete a trial, sometimes the accrual can take several years. Then after the accrual, so patients are enrolled and have completed treatment and the study is closed, then there is an analysis of the trial that includes not only the efficacy but safety, and then usually the application is submitted to the FDA. And depending on the safety and the efficacy profile, then, usually, again, in these rare diseases, we already know that if the trial is designed in a way that shows that is superior to standard treatment, will be approved. So I think from start to finish, it can take many years.
Okay, thank you so much on that one. How common are autoimmune diseases in patients with cutaneous lymphoma? Not sure who would want to take on that one.
I would say it just depends what type of lymphoma we're talking about. I think specifically when it comes to cutaneous T-cells, there hasn't really been an association between the two, but maybe Dr. Pro can speak a little bit more to the B-cell lymphomas. I think there might be a little signal in that arena.
Yeah, I don't think it's very common autoimmune disease in patients with cutaneous lymphoma. It's more common in B-cell lymphoma, in particular some types of B-cell lymphoma, like marginal zone lymphoma. So I don't think it's common in patients with mycosis fungoides.
Okay, that's good to know. So we're going to talk about UVB again. I've heard NB-UVB can bring spots to the surface and almost seem to make skin worse before better. On average, how long does it get worse before the skin starts clearing?
It's a great question, and it's actually really important to keep that in mind. And I would say sometimes even taking a hot shower can immediately make the skin look a lot worse. And so we think part of it might just be that the increased warmth and blood flow to the skin might make spots that were always there just more noticeable, necessarily that it's making the disease worse. I would say because it takes roughly about 3 months before we start seeing improvement with phototherapy, we would tolerate things getting worse within those 3 months. Again, there's limits to how much we're comfortable with becoming more active during that time. With that said, we often prescribe topical steroids for someone to use while they're also doing phototherapy, just to keep comfortable and try to keep those mild flares under control while we get you on more stable dosing for the phototherapy.
All right, thank you. Next question is, I have both hyper and hypopigmented lesions. Is this typical for mycosis fungoides?
Yes, it can be. So we have some folks who have mycosis fungoides where it's just pink or red scaly spots. We have some folks that just have white spots with no scale, or have a mixture of dark spots and light spots. I would say it all depends on what your disease is doing, and sort of what the dermatologist or oncologist uses to follow sort of your own internal benchmark. But certainly we've seen both light spots and dark spots in folks, not just the classic red spots.
All right, it is good to know. Everybody's going to look a little bit different. So are either of you aware of any new protocols for treatment that are out there?
Yeah, I think there are many protocols that are new and are using, immunotherapy. We are learning every day more about this disease, and basically we are trying to find way to attack cells, and specifically only these cells. So that's why we are using novel antibodies. So that's immunotherapy that recognize something that is abnormal in the cancer cell. And basically this antibody will attack only the cancer cell. So there are many new antibodies that are currently being explored in clinical trials. As I mentioned earlier, and I think there was a question about it, there are also a number of studies that are looking at the possibility of using CAR T cell therapy. So I think this is probably the area that has progressed the most in this field, the area of immunotherapy. There are also something you're probably familiar with, they're called checkpoint inhibitors, also a type of immunotherapy that has been really used a lot in patients with solid tumors like lung cancer and melanoma. And we know in some patients, not all of them, with mycosis fungoides, this form of therapy also is very effective.
Okay, thank you for sharing that. We're having some more questions on spots. If the visible spots for patients with stage 1A MF disappear, how often would you recommend your patient to check?
That's a good question. I would say there's sort of two approaches to that. One is, how often should your doctor check in on you, and how often should you be checking in on yourself at home? The truth is, I would say I wouldn't be searching for spots. I would say if you feel a spot that's bothersome, sort of it's itchy, scaly, and then you notice it, then I think there's really no urgency to start treatment and to be on high surveillance. So I think it's reasonable to let your body call attention to it. With that said, there's some areas of their body that are, readily visible. And so if you see a, certainly can have a discussion with your primary caregiver regarding what's the next best step in terms of treatment. But I don't know that I instruct patients to actively look for spots, but rather if they notice a spot, then we can talk about treatment at that time. In terms of how often I see patients, it really depends on a number of factors, from have they newly been diagnosed, have we started a new treatment, and I want to make sure that they're using it correctly or not having any difficulty. So I might see patients with 1A mycosis fungoides as often as 3 months, or as often as a year. So it really depends on where you are in your disease course.
Okay, thank you for the information. So we skipped a question, so we'll come back to that one. So again, people like to share information, and I like the fact that someone's coming to a professional to ask the question. But when using online forums amongst patients, there are statements around what we should and shouldn't do. Can you confirm these 3 things are safe? Using a sauna, getting a facial, and having a deep tissue massage.
So I'd say for question number 1, can I use a sauna? With respect to the skin and patients who have early stage mycosis fungoides or even some advanced stages, I personally think it is okay to use a sauna if you don't have any other medical problems where using a sauna would be contraindicated. And that would be a good conversation to have with your primary care doctor. In terms of facials, I see no problem with having a facial. Only concern would be is if you had active disease on the skin where someone is using abrasive tools, or you're exposing the face to sort of different chemicals that might be more irritating. I may hold back on doing a facial if you have active disease on the face. And as far as the deep tissue massage, I think everyone deserves a good massage, and there is nothing that you or the massage therapist should be concerned or worried about. Again, the stress is that if you have any open skin lesions, obviously I wouldn't want any oils or extra hands directly on those spots to minimize the risk of infection.
Dr. Pro, would you like to add anything on that?
No, I think I totally agree with Dr. LaRocca. Yes.
Okay. All right. So this next one, I want to reiterate again, because if someone's asking a very specific question, this is something to discuss with your physician. Dr. LaRocca and Dr. Pro can give you their opinion based on patients they've seen. So I'm a 51-year-old Black woman recently diagnosed with stage 1A MF. I have patches. My treatment consists of doing PUVA light therapy. I'm concerned about the risk factors with PUVA. Would switching my treatment to UVB therapy interfere with my progress?
I think this is a great question because it really is a good discussion to have directly with your primary provider. And I think some of the things that I think about is, if someone is older and if someone is of a darker skin type where actually the risk is far lower, then the risk of PUVA is actually probably not as significant as someone who has very fair skin and can easily burn. So it's definitely a different risk-benefit discussion. I would say that narrowband UVB absolutely can be used for stage 1A MF, even in individuals who are darker skinned. So I do think there's still some benefit to be derived from narrowband UVB. But one thing that I've seen with PUVA is that the benefit of it's possible that over the long term, some folks are able to keep their disease in deeper remission and go to treatments at greater intervals with PUVA than with narrowband UVB. So for example, with narrowband UVB, you're often on it 3 days a week for several weeks to months, and then that slowly gets tapered. And if someone requires maintenance therapy with narrowband UVB, you might go on it for a week. With PUVA, sometimes you're able to get away with doing it once a month. So in that sense, there's much more to be desired with PUVA than there is with narrowband UVB. And not all MF is the same. There's some MF that's very thin. There's some that's thicker. And for thicker disease, PUVA is better. So again, it's a difficult question to answer because it all depends on your individual risk-benefit profile and then specifics about the disease.
Okay, thank you. And it kind of is rolling in because we're getting a lot of questions about NB, UVB, UVB, and PUVA today. So diagnosed with MF1B, being treated with NB, UVB, and I can never say it right, acetrin. You can correct me on that one. Thank you. How long do you typically continue to treat a patient in remission before reducing or stopping treatment?
This is a tough question, actually. And I think it all comes down to the fact that there's actually two different philosophies as to how we treat this disease. There are some folks that prefer to always maintain some form of therapy on and think of treatment as a form of maintenance therapy because it's difficult to cure this disease and often something that can't be achieved in the early stages. So the reasoning is by keeping you on narrowband UVB and acitretin, we prevent the disease from coming back. The alternative approach is, well, these are therapies that take a lot of time out of could be potential side effects like dry skin with the acitretin, ongoing. And so why don't we use these therapies to get your disease in remission, and then let's start to pull back and stop therapy and only restart treatment if the disease comes back. And that could be in a couple of weeks, or it can be months to years. So it's difficult to gauge in which of those two camps your doctor believes is best for you. In general, once you achieve a remission, I can talk specific for band UVB, we tend to continue it at least for 3 months. Even though you're in a complete response, we continue it for 3 months as a form of consolidation phase. And then over a series of 1 to 3 months after that, slowly taper down. Because the thinking is the more aggressive we are and more consistent we are with treating the disease up front with narrowband UVB, when we do stop it, you're less likely to recur in a short. It take longer for the disease to come back, the longer you're on narrowband UVB, which involves treating you even though you have no disease. So again, it's a couple of different ways to answer that, and it really depends on also how aggressive your disease and how challenging it was to get it into remission in the first place. So not a straightforward answer.
Oh, a lot of these questions, it's a little tough. Real quick, I just want to say that we have a little over 10 minutes left. We have about 3 or 4 questions left in the queue. So if there's anyone that wants to get their questions in before our hour is up, please put it in the Q&A tool. All right, has THC or CBD been studied for the use to either treat cancer cells specifically or the pruritus?
Not that I know, but
I haven't heard anything, but you guys have your ear more to the ground. So we don't have anything out there. So we'll have to wait and see how that goes. How often should patients with MF check their blood?
So I'd say, I'm assuming this is an early stage patient. I think if it's a patient who at baseline had no evidence of disease in the blood, unless there's a significant disease change in the character of that patient's disease, sort of evidence in the skin of disease progression, I do not routinely recheck the blood work.
So we did get a little bit more different question that and Mike hasn't had a chance to put it up yet. For MF stage 1A, how often should I check my blood work to make sure the cancer doesn't progress into the blood? So that's a little bit more of a question on that.
And it would be the same answer. We don't recheck it because we don't expect it to. Something would really have to change dramatically in the skin for it to appear in the blood.
Okay, perfect. All right, right now, we have one more that came after this. So this is our second to last question at the moment. When using topical cream, is the expectation that spots will disappear or just fade? And how long can it take with daily use for patches, plaques to disappear?
Yeah, it's a great question, and it's difficult to answer. Probably this is the most challenging thing when counseling patients. So my hope is that the spots completely go away and the skin is left normal. Some people are able to achieve that. However, not everybody. There are some folks where the degree of inflammation from the disease itself leaves behind discoloration in the skin once it's completely treated. And that discoloration, or it might be a kind of a dusky purple red color, or it might be a change in the texture of the skin. So the disease might be completely gone, but the skin feels very wrinkly and thin. And so while some patients are lucky and the spots go away and the skin looks completely normal, some folks who are able to achieve complete remission and completely get rid of their spots might be left behind with some residual discoloration or texture changes. And your dermatologist can walk you through after treatment. Each different medication, each different cream or gel takes a very different amount of time to work. It could be as soon as 2 weeks for some individuals with topical steroids, or 6 months on Valcor gel. And so it's difficult to say how long it would take for any given spot to improve. It really depends on the medication.
All right, thank you. This is a question that we actually get quite a bit, and it's a statement that we hear and that patients like to hear it, but then also knowing they have to deal with it their entire life, is can early stage patients with MF live with it for 30 plus years? You hear this is something you die with, not from. How true is this statement?
So I wholeheartedly believe in this statement. I think it is true for patients with 1A disease. As I mentioned before, there is a small percentage of patients where that might not be the case, where they may go on disease progression. That doesn't necessarily mean they're going to die from their disease, but there are some folks that unfortunately do succumb to their illness who started with 1A disease. So I do want to be transparent that that is not the case for everyone, but for the vast majority, that is the case.
Okay, thank you. Does large cell transformation always mean it will attack internal organs?
I can take that, and then maybe Dr. LaRocca can also add her experience. So not necessarily, okay? There are some patients where we do multiple biopsy because something has changed with the disease and we feel like it's getting a little bit more aggressive. And we do find evidence of large cell transformation in the skin. But when we do imaging study, because again, if you find large cell transformation in the skin, you need to find out whether or not any of the organs are involved. So you need to have either CT imaging, so CAT scan, or these days we prefer a PET scan. And so to make sure that there are no lymph nodes or any other organ involvement. So in some patients, the large cell transformation is confined to the skin. But in other patients, absolutely true, it can attack other organs. So we need to find out, because if that is the case, they will need systemic chemotherapy. That's usually what we typically do.
Okay, thank you so much. Is it possible for viral and bacterial infections to aggravate, flare up the disease?
I think it's a great question. I would say that we don't have the data for viral illnesses, although anecdotally some patients might feel when they're sick, some areas of their disease flare. I have to say that's purely anecdotal and has not studied to be true. But when it comes to bacterial infections, specifically Staph aureus, so for example, staph infections, that absolutely can drive disease flares and activities. So some patients with just starting antibiotics or even bleach baths can notice a significant improvement in their disease.
Okay, thank you. So I'm going to try and paraphrase how they want it. I'm assuming that they've had a singular nodular formation that is involved over 2 years and grown to about 1 inch in diameter. So the question is could it be LYP?
It's a tough question to answer without the biopsy. I would say it all begins, well, so how do you make a diagnosis of lymphomatoid papulosis? It involves clinical pathologic correlation. So you need someone to evaluate it, like a dermatologist or an oncologist, and you need a biopsy. And I think once you have those two pieces of information, you'll be able to say whether or not it falls well within the category of lymphomatoid papulosis or not. The one thing is that part of the definition of lymphomatoid papulosis is something that goes away on its own without treatment. And while it might take weeks to months for some folks, 2 years is quite a long time. So I would say that it's important to have a biopsy and a clinical exam to really make the accurate diagnosis.
Okay, thank you. So we're going to have time for 2 more questions. So our next one is bone marrow transplant considered a curative option? Dr. Pro, do you want to tackle on this one?
Sure. I think, in advanced stage disease, you would not offer a bone marrow transplant in patients with early stage disease. But in advanced stage disease, we do think that bone marrow transplant is probably the treatment modality that will offer the best chance for a cure. Although I have to tell you that a number of patients after stem cell transplant can actually have recurrence of disease, but in most cases, I would say the disease has a different clinical course. Typically, patients who have a transplant and have progression afterwards have very limited disease. And in those cases, we tend to treat them with some sort of maintenance therapy. So it's curative for some patients, but not for all. And that's why we need to really try to find more effective therapy that is not bone marrow transplant. Also, it's very hard to achieve what we call a complete remission, meaning that complete clearing of all the skin lesion and any other lesion that is in any organ with currently available therapies. And the best chance for cure is in patients who have no evidence of disease before transplant, but this is very difficult to achieve.
Okay, thank you. This is going to be our last question of the night. So for someone who has skin tumors, has been through total skin electron beam therapy, but still gets persistent tumors, any suggestions on treatments? TSEV has slowed things down, but they seem to come back.
I would say
It's a
that
good one.
radiation in general is a very good modality, even for thick lesions like tumors, but there is a limit to how much radiation one gets. And if your prior experience with radiation was that it was only of limited benefits, then I would turn to someone like Dr. Pro for alternative options, the skin disease which sounds advanced if there are tumors.
Dr. Pro, would you like to add on to that one?
No, I agree with Dr. LaRocca. I think, if the radiation therapy is not able to really improve the disease burden, especially if there are, lesions, tumors, I think, the best option will be systemic therapy.
So our bonus question, for MF stage 1A using a topical steroid, is it okay to use the cream 1 week on and 1 week off? Will this help the cancer progress or strengthen?
That's a great question. And the truth is, there's actually many different ways to use topical steroids to achieve the end result, which is to stop disease progression. Using it 1 week on, 1 week off is a helpful balance to minimize side effects from the topics, and it might be enough for you to keep your disease at bay. Some folks might need to use it more often, and so it can really be tailored to the individual. And so I would say it is not something that would make your disease worse in any way, and certainly can be helpful. And if that's not working, then there are other ways to use it.
Okay, thank you. So that is going to wrap up our questions and answers for tonight. I wanted to say thank you both for taking time out of your busy schedule. And I wanted to give a special thank you from our board of directors. We really appreciate all of the engagement that you guys do and your dedication to the patients with cutaneous lymphoma and your help to the Cutaneous Lymphoma Foundation. We really do appreciate everything you do for us and for our patient community. And before we say goodbye, I want to say, do either of you had any additional parting thoughts?
I have to say that it's been an absolute pleasure. These are really great questions, and I look forward to learning more about them with you guys. And wherever I learn some new tricks or pearls, I'd be sure to share it.
Same here. It's been great to be able to join you today, and thank you for the great questions.
All right, and thank you everyone for attending. We look forward to seeing you at future programs. And please, please, please don't forget to take the survey. We use this survey to help determine our future programs and to try and fit the needs that you all are looking for. Thank you all and good night.